but to inspire responsibility and action. We are honored to have with us an esteemed panel of speakers today. Dr. C.B. Tripathi, President, National Medicos Organization. NMO focuses on developing socially responsible and service-oriented medical professionals with a strong emphasis on primary healthcare, community outreach, health awareness, and service to underserved populations. Its work in shaping values, discipline, and national responsibility among young medical professionals makes its perspective especially meaningful to today's theme. Due to an urgent meeting with Director General, Professor Dr. Pankaj Bharadwaj could not join us today. So we have Dr. Manoj Gupta, Academic Head, School of Public Health and Additional Professor, AIIMS, Jodhpur, and Joint Editor, IJCM. We also have in our panel Dr. Om Prakash Bera, Regional Advisor, Asia, Global Health Advocacy Incubator, and Dr. Venkatesh Karthikeyan, NCD Chair, World Medical Association. We sincerely appreciate all our speakers for contributing their time, expertise, and leadership to this important dialogue. I would now like to invite our first speaker, Dr. C.B. Tripathi, sir, to speak on Swami Vivekananda's philosophy and nation building through youth health, a public health perspective. Over to you, sir.
जी नमस्कार आप सभी को, जो भी आज उपस्थित हैं पूरे एम्स से मोस्टली और पूरे देश के दूसरे मेडिकल कॉलेजेस से। मैं डॉक्टर सीबी त्रिपाठी, जैसा कि मेरा परिचय दिया गया, और मैं एनएमओ नेशनल मेडिकोज ऑर्गेनाइजेशन का अखिल भारतीय अध्यक्ष होने के साथ साथ ऐसा जो भी कुछ स्वामी विवेकानंद जी को लेकर के हमने किया है उसी के संदर्भ में बात करना है। सर्वप्रथम तो आपको स्वामी विवेकानंद जयंती के उपलक्ष्य में हार्दिक शुभकामनाएं। आप जो स्वामी विवेकानंद जी ने बोला है कि अराइज अवेक, कि मेरे पीछे भी आप लोग देख रहे हैं, अराइज अवेक एंड स्टॉप नॉट अंटिल द गोल इज रीच्ड, ये सब चीजें हैं। तो अभी जो स्वामी विवेकानंद जी को लेकर के जो हम बात कर रहे हैं, तो स्वामी विवेकानंद जी ने कहा कि हमको गीता का तो ज्ञान होना चाहिए, पर इसके पहले हम लोग खुद बने, फिट बने। हम लोग कम से कम 1 घंटा फुटबॉल खेल सकते हैं क्या? नेशनल मेडिकल कमीशन ने जो भी कुछ किया, आजकल 8 घंटे में लड़के थक जाते हैं। अभी आप पुराना जो पीढ़ी है वो देखिए, 24 घंटे काम करता है लगातार, एक बने टेबल पर सिर रख करके सो लेता है, क्योंकि वो एक तरह से फिट है। फिट है तो हिट है, फिट रहेंगे तो हिट रहेंगे। नहीं तो क्या हुआ कि हमने एक, आप ऑपरेशन थिएटर में काम कर रहे हैं, एक ऑपरेट किया, उसके बाद 2 घंटे बाद थक गए। तो थक गए तो ऐसा नहीं, 6 घंटे 8 घंटे कभी कभी सर्जरीज चलती हैं। तो यदि डॉक्टर्स फिट नहीं रहेंगे तो काम कैसे होंगे? तो इसलिए फिटनेस बहुत जरूरी है। नेशनल मेडिकल कमीशन ने जब से कॉम्पिटेंसी बेस्ड मेडिकल एजुकेशन चालू किया, तो उसके पीछे जो भी डाले गए, तो उसमें जो भी स्वामी विवेकानंद जी के संदर्भ में पढ़े हुए थे, तो कई सारी चीजें डाली गई। अब हर मेडिकल कॉलेज में जिम्नेजियम होना चाहिए। तो जिम्नेजियम सिर्फ ऐसा नहीं, फंक्शनल होना चाहिए। उसका विद्यार्थियों उपयोग कर रहे हैं कि नहीं कर रहे हैं? मेडिकल कॉलेज हॉस्टल्स में, गर्ल्स, इवन गर्ल्स हॉस्टल में, मेडिकल कॉलेज प्रेमाइसेस में भी मतलब जिम्नेजियम हो, वहां पर टेबल टेनिस के टेबल हो, बैडमिंटन के कोर्ट्स हो, जहां भी व्यवस्था हो, तो लॉन टेनिस के कोर्ट्स हो, जहां फुटबॉल है, क्रिकेट है, खेलें बच्चे। खेलेंगे तो स्वस्थ रहेंगे, स्वस्थ रहेंगे तो ये सब चीजें रहेंगी। तो स्वामी विवेकानंद जी के कॉन्सेप्ट को लेकर के जब हम आगे बढ़ते हैं, तो काफी सारी चीजें हम लोग समाज में कम कर पाएंगे। हेल्दी सोसाइटी चाहिए। लाइफ स्टाइल डिसीज नॉन कम्युनिकेबल जो बढ़ रही है, तो उसमें से अभी जैसे हमारे एम्स की बहन ने बताया कि सोसाइटी में आज जहाँ कहीं भी हम कहीं विद्यार्थियों के घर पर विजिट लेने के लिए जाते हैं, और जब पता चलता है कि वो डीन आ रहे हैं मिलने के लिए, तो पूरा 3-4 सब मौसा मौसी सब जने आ जाते हैं। तो कहीं से पूछो तो किसी को हाइपरटेंशन है, किसी को डायबिटीज है, कोई को ओबेसिटी है, मायोकार्डियल इंफार्क्शन है, डिप्रेशन है, कार्सिनोमाज है। तो ये सब सोसाइटी में चेंजेस जो आए हैं उसके कारण से ये सब चीजें हैं। स्वामी विवेकानंद जी ने जो कहा है कि मतलब फिट रहिए, फिट रहिए, तो यही बात हम मेडिकल स्टूडेंट्स के बीच में या कहीं पर भी सोसाइटी में भी जाकर के बात कर रहे हैं। तो हम लोग सेवा समूह से जुड़े हुए संगठन है और उसको लेकर के कार्य कर रहे हैं। अब जब ये जाते हैं स्टूडेंट्स के घर पर विजिट करने के लिए, तो तब जा करके सब बातें करते हैं। तो हर घर में बीमारी क्यों है, तो हमको बीमारियों की संख्या बढ़ाना है या घटाना है। ये नॉन कम्युनिकेबल डिसीज जो बढ़ रही हैं, इसको लेकर के बड़ी चिंता का विषय है। हम लोग 140 करोड़ प्लस आने देशवासी हैं। आपको ये जानकर के बड़ा आश्चर्य होगा कि अभी इंडियन आर्मी में 12,000 आर्मी ऑफिसर्स की पोस्ट खाली है। मैं रिपीट कर रहा हूँ, आप जा करके चेक करिए। तो इतना बड़ा देश है और अभी हम लोग एक अने हेल्दी यूथ नहीं दे पा रहे हैं, क्योंकि हम अने पुराना सब भूल गए। अरे स्वामी विवेकानंद जी वो क्या गेरुआ वाले बाबा हमको सिखाएंगे। पर उन्होंने जो यदि किया होता, यदि हम स्वामी विवेकानंद जी को फॉलो किए होते, आज जो आर्मी में 12,000 आर्मी ऑफिसर की पोस्ट की कमी हो रही कहाँ से होती। सैनिकों की संख्या पूरी है, मानी बात, पर आर्मी ऑफिसर की पोस्ट क्यों कम हो रही है। तो ये सब जो भी हम लोग मेडिकल प्रोफेशंस में हैं, वो हम सब की रिस्पॉन्सिबिलिटी है कि सोसाइटी स्वस्थ रहे। जिससे कहीं उसको मैं स्वामी विवेकानंद जी से जोड़ करके बताना चाहूंगा कि पहले समय में अच्छा डॉक्टर या वैद्य किसको कहा जाता था, वो जहां पर प्रैक्टिस कर रहा है या जहां पर है, उसके 50 कोस की पेरीफेरी में कोई भी बीमारियां ना हो या बीमारियां कम हो, उसको अच्छा वैद्य या डॉक्टर गिना जाता था। तो ये सब चीजें जो हमारी पुरानी चीजें हैं, मान्यताएं हैं, उनको स्वामी विवेकानंद जी से जोड़ करके ये सब चीजें हमारे मेडिकल के स्टूडेंट्स में इम्बाइब हों, तो एक सोसाइटी हम लोग स्वस्थ रख पाएंगे, भारत को स्वस्थ रख पाएंगे। और फिजिकल फिटनेस का अपना एक आने इम्पोर्टेंस है, उसमें ये तो है ही ना। यदि फिजिकली फिट हैं तो लड़के समाज में, मतलब वार्ड में जो भी हैं, हम ज्यादा से ज्यादा पेशेंट की हिस्ट्री ले पाएंगे। तो फिटनेस जो स्वामी विवेकानंद जी ने बताया कि, जो मैं फिर से रिपीट कर रहा हूँ, कि गीता का ज्ञान तो हो, पर उसके साथ में बच्चे फिट भी होना चाहिए, मेडिकल स्टूडेंट। नहीं तो आजकल क्या हो रहा है कि चेहरे पर आने वो चमक ही नहीं है, नूर ही नहीं है। नहीं तो पहले तो लग जाता था कि ये सोसाइटी में ऐसा बोलता था, अच्छा ये कोई बिल्कुल डेफिनेटली मेडिकल स्टूडेंट होगा। उसमें अभी जो भी परिवर्तन मतलब कि सोसाइटी के कारण से होते जा रहे हैं, तो उसमें से बच्चे ही यानी डिप्रेस्ड हैं। डिप्रेस क्यों है भाई। तो नेशनल मेडिकोज ऑर्गेनाइजेशन ने स्वामी विवेकानंद जी का ही एक उदाहरण, मतलब उनको उद्देश्य बना करके साइकिल चलाओ स्वस्थ रहो, हर नो कार बुधवार। उस दिन आने आपको पैदल चल के आना है। हमारे प्रोफेसर, सीनियर प्रोफेसर 1-2 किलोमीटर की पेरीफेरी में जो रहते थे, चाहे पैदल चल के आते थे, बच्चे साइकिल पर आते थे। उस दिन आने जो भी हैं, बन सके तो कार शेयरिंग डे, नो एयर पॉल्यूशन डे, ऐसा करके सब चीजें करते थे। तो ये सब चीजें जो करते थे, तो ये सब चीजें होती हैं। जैसे आज स्वामी विवेकानंद जयंती है, तो पूरे देश भर में कहीं पर कुछ कुछ कॉलेज आने साइकिल आने रैली कर रहे हैं। जैसे किसी बड़े सिटी में 5 मेडिकल कॉलेज हैं, तो उस पांचों मेडिकल कॉलेज में विद्यार्थी साइकिल से जुड़ेंगे। तो वो जो उसमें स्ट्रेंथ बढ़ेगी, स्टेमिना बढ़ेगा, और बच्चे इस तरह से निडर बनेंगे। यानी डरे हुए बच्चे क्या मतलब है। अब वो जैसे कि बच्चे जो हैं, मतलब कि यदि डरे हुए रहेंगे, फिटनेस नहीं रहेगी, लड़कियां हमारी डरी डरी से रहेंगी। अब जैसे हम लोग सिखाते हैं कि भाई क्यों नहीं रानी के झांसी की रानी बन सकती हैं, क्यों नहीं है रजिया सुल्तान बन सके, आप रानी दुर्गावती बन सकती हैं। अने हो सक बंद करने के लिए बोलो ना उसको, उसको बोलो कि अभी बाद में बात करेंगे, उसको साइलेंट मोड पे करवा दो। हाँ, तो उसमें जो मतलब क्यों नहीं हो सकता है। अभी जो भी हम स्वामी विवेकानंद जी का उदाहरण लेकर के जब आगे बढ़ेंगे, तो आज जो भी आरजी कार मेडिकल कॉलेज में घटना बनी, तो उस लड़की को हमने कहीं से, मैं ऐसा मानता हूं, और मैं अभी तक उस बात को लेकर के कचोटता हूं कि हम उसको ये शिक्षा नहीं दे पाए, स्वामी विवेकानंद जी वाली, कि भाई कि फिट है तो हिट है, और कोई योग्य पात्र मिले तो उसको 6 इंच छोटा भी कर सकें। तो ये सब चीजें हो जाएंगी। तो तो वो स्वामी विवेकानंद जी को हमको पूरे मतलब कि शरीर में इम्बाइब करना पड़ेगा, हमारे यूथ को ले जाना पड़ेगा, तब जाकर के ये सब चीजें होंगी। और मेंटली स्ट्रेंथ, मतलब मेंटली स्ट्रांग बनाने का है। अभी जैसे कि आपने अभी अभी आप सब लोग ने एक्टिव हैं सोशल मीडिया पर, अजय डोवल जी 81 ईयर, 81 साल की उम्र है, और अभी जो उन्होंने दिल्ली में 3,000 कार्यकर्ताओं को लेकर के, उनके आइकॉन भी, अजय डोवल जी के आइकॉन कौन है, स्वामी विवेकानंद जी। तो उन्होंने जो कहा वो उसको आप 32 मिनट्स का एक वीडियो है, उसको देखिए। तो उसमें हम लोग भी उससे भाई मतलब हम लोग भी उससे इंकरेज होते हैं, मोटिवेट होते हैं इस उम्र में। तो स्वामी विवेकानंद जी ने जो भी कुछ कहा है उसको लेकर के हमारा सेल्फ कॉन्फिडेंस, यस हम ये कर ही पाएंगे। भारत को अभी तक नोबेल प्राइज नहीं मिला है। तो नोबेल प्राइज क्यों नहीं मिला है? मेडिसिन में उसमें आपको इकोनॉमिक्स में मिला है, इकोनॉमिक्स में मिला है, और लिटरेचर में मिला है, फिजिक्स में मिला है, केमिस्ट्री में मिला है। तो उसको सबको मेडिसिन में क्यों नहीं मिला है? तो अभी हमको सभी मेडिकल स्टूडेंट्स को जब मैंने ये सब बातें बताएंगे कि हमने एक टारगेट लिया, उसी टारगेट को लेकर के पूरा करेंगे, तो डेफिनेटली भारत को नोबेल प्राइज मिलेगा। तो इसको लेकर के, और अब हम ये सब बातें जब स्वामी विवेकानंद जी से लेकर के कि हमको थकना नहीं है, फिजिकली फिट रहना है, मेंटली स्ट्रांग रहने का है, सेल्फ कॉन्फिडेंस बना के रखना है, क्यों नहीं रख सकते? भारत को नोबेल प्राइज क्यों नहीं मिल सकता है? एम्स न्यू दिल्ली के डॉक्टर बलरामन के नेतृत्व में वैक्सीन बने, तो कैसे बने? क्या क्या डिफिकल्टीज नहीं आई? हमको रेशेस मंकी नहीं मिले, चाइना ने एक्सपोर्ट करने को मना कर दिया। ठीक है, तो हमने कहा ठीक है कोई बात नहीं, तो प्लान ए फेल हुआ तो प्लान बी पर काम हुआ, और वैक्सीन समय पर आए, और फाइजर कंपनी जो अमेरिका की थी उसके नहीं आने दिए। तो इसके पीछे काम करने वाले जो व्यक्ति थे वो कहीं ना कहीं से स्वामी विवेकानंद जी से प्रभावित थे। यस, वी विल डू इट एंड वी कैन डू इट, और वो उन्होंने सिद्ध करके बताया। तो यही है उसमें। अभी जैसे कि मैं अभी अजीत डोयल जी की बात कर रहा था, अभी जो उन्होंने अभी दिल्ली में दिया था, उसमें ये है कि लीडरशिप लीडरशिप यानी प्रॉपर होना चाहिए। जैसे कि 1,000 भेड़ें हैं और उसका यदि नेतृत्व कोई शेर कर रहा है तो वो भेड़ें जीत जाएंगी। पर 1,000 शेर का नेतृत्व एक भेड़ कर रही है तो डेफिनेटली वो आर्मी हारने वाली है। तो वो नेतृत्व भी ठीक से होना चाहिए। तो यही सब चीजें स्वामी विवेकानंद जी ने जो हमारे के बीच में बताने की कोशिश करी है, उसमें सब चीजें करना चाहिए। और हमको फिजिकली तो फिट रहना ही है। ये लाइफ स्टाइल डिसीज कैसे आ गई? अब जैसे कि जिम्नेजियम है, स्विमिंग है, साइकिलिंग है, जो भी कुछ है, यानी आपको रनिंग है, जॉगिंग है, सब करना है। अब जैसे मेडिकल में डिप्रेशन का आ, 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 और भी मतलब परिवार के लोगों की याद आ रही है, ये सब चीजें हैं। तो हम लोग जब मिल करके सब ने ये सब चीजें डालेंगे, साइकिलिंग करेंगे या स्विमिंग करेंगे या हम लॉन टेनिस खेलेंगे या टेबल टेनिस खेलेंगे, तो नेचुरली हमारा सीरोटोनिन लेवल अप जाएगा। उनको सिलेक्टिव सीरोटोनिन रीअपटेक इनहिबिटर्स लेने की जरूरत ही नहीं रहेगी। डिप्रेशन में क्यों जाएगा मेडिकल स्टूडेंट? और अभी तो नेशनल मेडिकल कमीशन ने इतना अच्छा सब मतलब निर्णय कर रखा है कि भाई कि हर एक टीचर के साथ में 10 मेडिकल स्टूडेंट्स हैं, और उस मेडिकल स्टूडेंट्स का पर्सनल सोशल एकेडमिक पूरी की पूरी जानकारी उन 10 स्टूडेंट्स की उस टीचर के पास में होना चाहिए। तो हम लोग यदि स्वामी विवेकानंद जी को फॉलो करते हैं तो जो मेडिकल कॉलेजेस में डिप्रेशन के या सुसाइड के केस जो हो रहे हैं उनको सबको लेकर के हमको करना है। दूसरा ऐसा है कि कॉम्पिटेंसी बेस्ड मेडिकल एजुकेशन आया, तो अभी लोग हम फर्स्ट ईयर के बच्चों को ही हेल्थ कैंप्स के लिए ले जा रहे हैं। तो हेल्थ कैंप्स के लिए क्यों ले जा रहे हैं? कि अर्ली क्लिनिकल एक्सपोजर। अब वो कहेंगे नहीं नहीं वो थक जाता है, वो उसको ठंडी लगेगी, वो गर्मी में राजस्थान में जाकर के कैंप्स में, अरे कैसी बात कर रहे हैं, कैसी बात कर रहे हैं? गर्मी में क्यों नहीं हो सकते अप्रैल में मेडिकल कैंप्स? जहां जैसी परिस्थिति वहां पर वैसा करने का है। यस, हम लोग वहां पर सेवा करने के लिए जा रहे हैं, ये स्वामी विवेकानंद जी के ही शब्द हैं, सेवा सेवा करने का है। तो सेवा, हम लोग वहां पर सेवा करने जा रहे हैं, सेवा करवाने नहीं जा रहे हैं। और यदि हमने 8 दिन गर्मी में रह करके काम किया या एक्सट्रीम कोल्ड में काम किया या हमने लद्दाख में काम किया, आप लद्दाख में जाकर के मेडिकल कैंप्स करते हैं तब आपको पता चलेगा कि वहां पर आने अप्थेल्मिक प्रॉब्लम्स कितनी है, टेरिज्म कितने हैं, और यहाँ पर आने कितने सब लोगों को जरूरत। नॉर्थ ईस्ट में जाइए तो आप विषम परिस्थिति हो सकती है, ठीक है, पर आप जाओगे तो वहां पर सब उनको प्यार मिला रहेगा। या वहां पर जो जो भी स्वामी विवेकानंद केंद्र चलते हैं, उनके उनसे द्वारा प्रभावित लोग हैं, उनसे बात करो तो उनको लगता है कि वो कितना सारा उस समाज का, उस एरिया का सब है वो लोग काम कर रहे हैं। कॉम्पिटेंसी बेस्ड मेडिकल एजुकेशन में जो भी फाउंडेशन कोर्स होता है, तो उसमें योग की ट्रेनिंग देने के लिए बोला गया है ना। 15 दिन सिखाइए और जिंदगी भर करते रहेंगे। तो ये जो भी अन्य चीजें नेशनल मेडिकल कमीशन के द्वारा लाई गई हैं, मेडिटेशन है, और उसके उसके द्वारा ये सब चीजें हम लोग आगे बढ़ेंगे तो ठीक रहेगा। यूथ जो है फिजिकली फिट तो हो ही, पर व्यसन मुक्त हो। कई सारी चीजें जो डाली गई हैं, और वो कहीं ना कहीं से जो एनएमसी में स्वामी विवेकानंद जी से प्रभावित लोग थे, उन्होंने वहां पर वो इम्प्लीमेंट करवाई। नशा मुक्त भारत अभियान। पंजाब में देखो क्या चल रहा है, पिक्चर्स बन रही हैं, उड़ता पंजाब, क्या चल रहा है वहां पर, नशा कितना हो गया है। अब यदि नशे अब ये सब क्या है कि नैरेटिव सेट होते हैं कि पूरे यूथ को नशे की तरफ ले जाओ, वो कंट्री खत्म हो जाएगा। तो हमको स्वामी विवेकानंद, हर विद्यार्थी स्वामी विवेकानंद जी का मतलब एक उसको फॉलो करे तो सब चीजें हो सकती हैं। और उनको बताना है कि आपने हर चीज को आने आप प्राप्त कर सकते हो। पावर इज विद इन यू, पावर इज विद इन यू एंड यू कैन डू एनीथिंग एंड एवरीथिंग। कुछ भी कर सकते हैं, एक बार आपको यस ठानने का है, यस आई आई विल डू इट, आई कैन डू इट। जैसे हम लोग बताते हैं, इंटर्नशिप खत्म हुई और आपको पीजी में एडमिशन मिल जाना चाहिए, 1 साल तक 2 साल तक आपको पीजी प्रिपरेशन नहीं करना है। और ये भी कहते हैं कि आपको गवर्नमेंट कॉलेजेस में जाना है जहां पर कि टैक्स पेयर्स आपको स्टाइपेंड देंगे। तो वो एक टारगेट दिया जाता है, तो वो टारगेट के पीछे ये भी है। तो उसके जमाने हम ये बार बार रिमाइंडर करेंगे। क्या नेशनल यूथ डे सेलिब्रेट किया, फिर हमने जो दिग्विजय दिन सेलिब्रेट किया 11 सितंबर, स्वामी विवेकानंद जी ने जो शिकागो में धर्म परिषद में भाषण दिया था। तो जब ये सब चीजें जब हम लोग स्वामी विवेकानंद जी के बारे में ये सब बताएंगे, तो भारत को यानी जो हम भारत के लिए चाहते हैं वो अति शीघ्र सब होने का होगा। तो जो भी स्वामी विवेकानंद जी के क्या और कर सकते हैं हम लोग, या हम लोग अभी मेडिकल कॉलेजेस में क्या कर सकते हैं। तो अभी आपको नो टोबैको प्लज, आप जाइए, तो उसको एनएमसी ने भी बोला है, नेशनल मेडिकल कमीशन ने भी बोला है, और हेल्थ डिपार्टमेंट ने भी, सेंट्रल हेल्थ डिपार्टमेंट ने भी बोला है कि हर लड़का मतलब कि टोबैको, नो टोबैको प्लज मतलब शपथ ले, सौगंध ले कि मैं नहीं खाऊंगा। नहीं तो क्या है कि अभी यूथ कहाँ जा रहा है, और अभी जो हमारा टैक्स है फिर वो कैंसर ट्रीटमेंट में चला जाता है। हम लोग टैक्स पर ईमानदारी से टैक्स देते हैं, गवर्नमेंट सर्वेंट हैं या मतलब जहां पर भी हैं, डॉक्टर्स हैं, तो वो सब है ना उस ढंग से ईमानदारी से टैक्स दे रहे हैं। तो ये सब चीजें जब आ रही हैं, एक जो स्वामी विवेकानंद जी का फॉलोअर रहेगा ना, तो वो टैक्स पे करेगा ही करेगा। और यदि मान लो 10,000 ज्यादा भी दे दिया ना, अरे कोई बात नहीं, अपने देश में ही तो गया ना, तो कहीं ना कहीं से बात आएंगी। तो हर मेडिकल कॉलेज में टोबैको सीजेशन सेंटर्स रहें, ये एनएमसी की गाइडलाइन है, हेल्थ डिपार्टमेंट की गाइडलाइन है, तो हम उसको करें। उसमें 4 डिपार्टमेंट इन्वॉल्व होते हैं, साइकेट्री, कम्युनिटी मेडिसिन, ओटोरैनियोलैरिंगोलॉजी एंड डेंटिस्ट्री। ये चारों डिपार्टमेंट मिल करके टोबैको सीजेशन सेंटर चलाता है। नशा मुक्त भारत अभियान का है, तो नो टू ड्रग। ये तो वही पंजाब सरी की हालत कहीं फिर होने की संभावनाएं रहती हैं। तो फिर कहाँ से हम लोगों ने हमने जो मतलब की पिक्चर्स बनी है, तो वो भी बच्चों को बताएं, और तब हम गौरव ले सकते हैं कि भारत किसी से कम नहीं है। भारत भी वैक्सीन बना सकता है, एक नहीं दो दो बना सकता है, तीसरा भी बना था, पर वो फाइनेंशियली मतलब वायबल नहीं था। जायडस मतलब कि फार्मास्यूटिकल कंपनी से बना था, तो 3 वैक्सीन बने थे, पर 2 को मार्केट में लाया गया। और हर जो भी 140 करोड़ प्लस पॉपुलेशन को, हर किसी को 3-3 डोज लगे, और हमने वो करके बताया। तो वही है, स्ट्रेंथ थी। यस, मेंटली मतलब हम लोग स्ट्रांग थे, और कहीं से इनडायरेक्टली डायरेक्टली हम कहीं स्वामी विवेकानंद जी को फॉलो कर रहे थे। तो ये सब चीजें सामने आई। तो इतना सब हुआ। मेरा टाइम कितना बचा है? हाँ, हाँ, तो यही है। तो अंत में यही कहूंगा कि हम जहां भी हैं, ये नेशनल यूथ डे जो कि सेंट्रल गवर्नमेंट का जीआरबी है, उसमें डरने की कोई जरूरत नहीं है। मैं आपको एक किसी एम्स की घटना बताता हूँ कि वहां पर है स्वामी विवेकानंद जी सेलिब्रेशन, उसमें से शायद उस कॉलेज के कुछ लोग जुड़े हैं, ऐसा लग रहा है मुझे। तो वहां पर स्वामी विवेकानंद जयंती सेलिब्रेट करने के लिए डायरेक्टर ने मना किया। मना किया तो वहां के एक स्टूडेंट ने सीधे सीधे प्राइम मिनिस्टर को रिपोर्ट किया, मोदी जी को। मोदी जी के ऑफिस से आया कि भाई व्हाई यू आर स्टॉपिंग द स्टूडेंट टू सेलिब्रेट द नेशनल यूथ डे ऑन द स्वामी विवेकानंद जयंती। तो उनको जवाब देना मुश्किल पड़ गया था। तो ये सब सेंट्रल गवर्नमेंट का जीआर है, हम सेंट्रल गवर्नमेंट के रूल्स के हिसाब से ही कर रहे हैं। आज ये जो आयोजन हुआ है, उसमें से एम्स राजकोट ने उसमें लीड लिया है, उसमें कम्युनिटी मेडिसिन डिपार्टमेंट के फैकल्टीज ने उसको लीड किया है। तो मैं उनको बधाई देते हुए मैं अपनी वाणी को विश्राम देता हूँ। भारत माता की जय, और फिट हैं तो हिट हैं। अस्तु, भारत माता की जय।
Thank you, sir, for your valuable insights. I now invite Dr. Manoj Gupta, Academic Head, School of Public Health and Additional Professor, AIIMS Jodhpur and Joint Editor, IJCM, to speak on hypertension and diabetes in young India, implications for surveillance, early screening, and public health systems. Over to you, sir.
Okay, thank you so much. Thank you. Very good afternoon, everyone. First of all, I'll take this opportunity to thank Dr. Kripal, who has given me this platform to speak about youth and non-communicable diseases. What are the need of screening? What is the need of surveillance? And what should be the policy priorities to change, especially for youth? Because today we are celebrating the Youth Day, respected Shri Swami Vivekananda Ji Jayanti. I'll share my slide and then I'll start. I hope it is visible. Is it visible?
Yes, sir, it is visible.
Okay, thank you so much. So in the next 25 minutes or 30 minutes, I'll be taking you through this important topic, which is related to non-communicable diseases. So primarily, I'll be talking about hypertension and diabetes, especially in youth, young India, I would say, which we include usually adolescent age group and young adults. And what is the implications for surveillance, for early screening, and what are the requirements to change the public health system in our country so that this particular age group can be catered and the non-communicable diseases can be handled in this particular section of the population. So to start with, definitely, sir also highlighted, we are experiencing a rising burden of non-communicable diseases in our country. The issue is, I could recall some 15, 16 years back when the program was started, this NPCDCS, at that time, the name of the program was. So it was a kind of thing like the health system was not prepared, or doctors or nurses, and we do not have resources enough to tackle these non-communicable diseases because they came suddenly into the country. They entered in a very fast pace, and the health system was not ready to handle that. But still, it is capturing, it is expanding its horizon, and now they have started penetrating into younger age or younger India, younger age of the population of our country. Most common emerging diseases, hypertension and diabetes, especially in youth, adolescent, and young adults these days. And the biggest issue is this early onset leads to complications in very early age, especially in adulthood. So by the time a person is 30 or 40, the complications start developing, which leads to premature mortality and morbidity. So this is very unfortunate for the country that these diseases are gradually penetrating, or I would say not gradually, speedily penetrating into the younger age group, which is leading to high morbidity and mortality at very young age in our country, and which is very much affecting the life expectancy as well as morbidity status of the country. I would start my presentation with I would say we usually talk about demographic transitions because India is relatively a young country. If you look at the population pyramid of the country, we all know what population pyramid is. So there are basically three things, three type of transitions are there, which is changing the demography or because of changing in demography, which is affecting the country now in India. Like first thing is we are increasing the share of aging population in the country. So we all know that aging population are gradually increasing, rapid urbanization again, second thing, because India again the transition phase of from developing to developer, we say as a mostly initial phase of development status. So rapid urbanization is there. And third important demographic transition, which we are going to discuss today, is one third of our population is of 10 to 24-year age group. So one third, you can imagine a kind of one third country or एक तिहाई देश हमारा 10 to 24 year के बीच में है. So this is the most important thing. I have certain data to look at it. If you look at this world population prospects in which the trend of different age group population was plotted till 2060 based on certain projections. If you look at this light blue color line, we can say sky blue color line, this which represent age group of 15 to 24 years, it increased so far and now going into stabilized phase. But if you look parallelly, this dark blue or we can say violet color line, it is sharply increasing, which is the elderly population in your country, because all the youth which has increased so far will be shifted to adulthood. So this is, I would say, the purpose of bringing this slide is to make you kind of sensitize that this particular age group is very important to tackle these days, because this is the foundation age in which, because we are talking about non-communicable diseases, all sort of behavior changes, all sort of bad habits, all sort of lifestyle changes start developing in this particular age in youth. So if we tackle youth today, if we take care of youth population today, or adulthood in the future would be healthy. Otherwise, it would be a difficult situation for a country to take care of such a huge population, which will be transformed into adulthood with lot many comorbidities and lot many mortalities issues. So we should definitely focus on youth population. If you look at the current scenario, this is a prospects or we can say distribution of 2024 population of a country, which is not very much has changed in last 1 year. Around half of the Indian population is under 30 years of age. The purpose of showing this slide is still 50% of the India is young India. So the thing is, I could recall when this program was started, there were a lot of discussions about deciding the age group, which age group was to be screened. Considering the available resources, it was decided that 30 plus population will be screened in our country. But now it's 16 years, 17 years backstory. Now the time has changed. We should rethink about it, and we should definitely think about bringing this screening age to some extent around 18 to 20 years, because now it's a high time to screen the population which is relatively younger, because disease has sufficiently penetrated into this age group. So though it's a big country, though resources may be a challenge, but it's time to take certain decisions in that regard. Looking at this huge number of youth in our population, there are two major issues, I would say. As a public health person, if you ask me to categorize the disease, there are multiple issues. But to be very true, I'll categorize them into two major issues in terms of one is non-communicable diseases, another one is mental health issues, which is gradually emerging into youth, or we can say early adults. WHO has recently given certain statement that 2/3 of the premature deaths and 1/3 of total disease burden in adults is associated with the conditions of behavior which we start in early age in our life. We can say in adolescence age or in youth age. Behaviors like using tobacco, substance abuse behavior, some sort of lack of physical activities, high risk behaviors, injuries, violence. So these behaviors lay down the foundation of those non-communicable diseases in early age, which leads to 2/3 of premature deaths among adults and 1/3 of total disease burden among adults. So this is a kind of scenario, because it's a kind of continuum which we should take care of. So that's why it's important to take care of this challenge as early as possible, because if you look at the global picture or Indian picture, both are almost same. This is a scenario of Indian scenario in which you can appreciate the transition starting from 1990 to 2016. 1990, where this non-communicable diseases used to contribute, mortality because of non-communicable diseases used to contribute almost 1/3, has changed to 2/3. Now these days, even more than or around 2/3 of the mortalities among adults are because of these non-communicable diseases. If you look at the recent picture in 2018, these are the major diseases which are contributing to deaths. 63% of deaths are because of non-communicable diseases among adults these days. And major diseases which are contributing in those non-communicable diseases leading to mortality are cardiovascular diseases, respiratory diseases, especially COPD, and other non-communicable maternal perinatal nutritional conditions. So this is the overall picture how NCDs have been penetrated into the system. Now, if you look at some sort of literature, some literature published on the major causes of non-communicable diseases or major leading causes of deaths because of non-communicable disease. These are the three diseases which has been highlighted, the most common causes of death in our country because of non-communicable diseases, in which number one is ischemic heart disease, or second is COPD or chronic obstructive pulmonary disease, and third is stroke. So these are leading causes of death these days in our country. Now, another picture is represented by some sort of data analysis by Global Burden of Disease study, which was published in Lancet. So they analyzed data of globally some 10 years data. And in this particular slide, you can appreciate that there are few red graphs and few blue graphs. So red graph shows decrease in the prevalence or percentages of diseases, and blue line shows increase in those percentages of number contribution to those diseases. So if you can see, especially diabetes, chronic kidney disease, stroke, COPD, and ischemic heart disease. These are 5 diseases which has drastically increased in 10 years, within 10 years time, more than some 1/3 to almost half, or 1.5 times increase in the diseases, which has changed the entire demand and supply of healthcare delivery system in almost all the countries, because this is a global data which I'm showing. Because of this change, or because of this transition, in terms of non-communicable diseases or leading causes of mortality, there is there are many risk factors which were identified, and the most common is, we can say, hypertension and diabetes. Because early onset of those NCDs, hypertension and diabetes, leads to ischemic heart disease, leads to stroke, leads to these leading causes of deaths. So there's a need to identify, we can say, or screen those diseases early in the life. So early detection may be a kind of backbone or mainstay. Second thing is, because these diseases are not into the routine surveillance system, this particular age group is not there in the program. So this youth population, somehow the data is not available with the country. If you ask me, what is the prevalence of diabetes or hypertension among youth population, especially in our country? I can say I have few systematic reviews. I have few surveys, national level surveys, but running data, or I would say surveillance data, or a kind of screening data is not available with the government of India, unfortunately, for this particular age group. So there is a dire need, or we can say need of to capture this data and to target this population. Though it will lead to some financial burden on our health system, definitely, but looking at the cost-effective benefit, or we can say cost-effective ratio, or though we do not have cost-effective studies and we cannot wait also for that, but still it's a high time to include this age group into the system for the screening and for the surveillance. Some facts I have collected, some epidemiological facts from the published literature and data. If you look at the data of hypertension among adolescents, so NFHS 5 says around 4% of adolescents, which we consider 10 to 19 year of age group, is suffering with hypertension. So this looks a kind of less, like 4%, but still, if you consider the number, it's a very high number. And this distribution is more in urban part as compared to rural part. So there may be multiple factors for that, mainly because of lifestyle changes. There is a systematic review, or many studies I searched for the prevalence of hypertension among youth, especially. So range is very wide. It's ranging from 2% to 25% in different parts of the country. This is for India. So in a systematic review, it says that the range is quite high, and we do not know like which part of the country is most affected with that. So we went into a distribution of regional perspective about it. And we try to do some sort of analysis and try to publish that regional differences in the prevalence of hypertension in our country. So if you can look at this map, most of the cases, or we can say highest prevalence, was noted in northeast region of the country, followed by southern part of India, though it was less in north region. But if you move from north to south, the prevalence is gradually increasing and it's going to the peak in the southern part. Definitely, northeast region has very high prevalence of hypertension, especially among adolescents. So this is the kind of regional variations we observe. It's relatively lesser in central India, and eastern India was the least reported prevalence of hypertension among adolescents. Though there are regional variations, but at least some sort of screening in the initial phases is required for this age group. If you talk about diabetes also, diabetes again, there is a lack of conclusive, we can say, robust data set to declare that this is the right prevalence of diabetes in our country. We had to rely on these surveys only. So CNNS, or we can say Comprehensive National Nutrition Survey, was the first survey in our country which took a kind of rough estimate, so which took a sample survey to estimate the prevalence of pre-diabetes and diabetes among adolescents in our country. This was the largest survey at that time in 16 to 18. So in which the boys or girls, if we can say roughly around 10% of the adolescents were suffering with pre-diabetes or diabetes. Again, the distribution was same. It was more in urban areas as compared to rural India. NFHS 5 has recently, in fifth round, has reduced the cutoff for screening of diabetes and hypertension. Now they are considering 15 plus age group as the cutoff to screen for diabetes and hypertension. That's a good thing. At least one survey, national level survey, has taken the initiative to take some data about the NCDs among youth population, especially. So in NFHS 5, it is 3.5% of adolescents who were suffering with diabetes. This is a confirmed diabetes cases. So again, the situation is alarming both for diabetes and hypertension. If we look at the epidemiological profile of our country, regional variations in our states of the country. There are few other evidences which says that the late adolescents, because we categorize adolescents into different parts, so especially 15 to 19 year of age group, they have significantly higher risk of developing non-communicable. Multiple factors are there for that reason. Maybe because of high academic pressure, maybe because of some career concerns which they have during that particular time, some sort of unhealthy dietary practices or unhealthy lifestyle practices which has already imbibed into the system or already imbibed into their routine practices are leading to this. Substance abuse behaviors, prolonged exposure to social media these days, that's another a very alarming situation, and less physical activities. So these are some of the risk factors which were identified because of this higher risk of non-communicable diseases in this late adolescent age group, which is, we can say, a transition phase between adolescent to, or we can say middle part of the early part of the youth, 15 to 19. We all know about the risk factors, which are very specific to the young population. They are not very much different from the adult population. But the same slogan I would use here, there are evidences, we need some policies, we need some actions, and we need some partnership to take care of those risk factors. Obviously, the risk factors are same, they are behavioral, they are intermediate, and they are endpoints. Endpoints we have discussed like cardiovascular diseases, COPD, diabetes, which are leading causes of deaths. But why these leading causes of death? Mainly because of high blood pressure, high BMI, high dyslipidemia, and again, diabetes, or we can say raised blood glucose. So somewhere we'll have to start working on these intermediate and behavioral risk factors. We should start, even before starting this behavioral risk factors, some sort of primordial preventions are required. The major risk factors: tobacco use, unhealthy diet, alcohol, and physical inactivity. These are leading causes or leading risk factors which are responsible for these non-communicable diseases. Obviously, there are some covariates like age, gender, genes, social social environment, economic factors, cultural environment. So these are some of the covariates, and definitely they are determinants and facilitators. So you all know that in your books, you can categorize them into modifiable and non-modifiable risk factors, but some sort of modifiable risk factors can be definitely modified to get a, or to be, so that we can have a healthy adults in future. We can have a healthy youth these days, and with some good lifestyle. if you look at the leading risk factors among all, the study says that unhealthy food consumption is the most important risk factor these days, which is contributing to those non-communicable diseases. This contribute to almost 52%, or we can say more than half of non-communicable disease. This is the most important risk factor to be taken care of these days. Unhealthy food consumption, maybe because of this latest change in food delivery apps and so many easy availability of unhealthy foods, chains of those unhealthy foods which has penetrated in our system or in our country like anything. Second most important thing is physical inactivity. Physical inactivity because of this, I would say, because of this screen time, increased screen time these days, young population, especially youth. Even I would say example of my own college, AIIMS Jodhpur, in which I saw students. They are busy in their mobile. They are scrolling the reels, and they don't want to go to the field and play at the evening. So some sort of physical inactivity. That kind of culture has penetrated into our colleges and to our youth. So that's leading to physical inactivity and ultimately to diabetes and hypertension, or we can say non-communicable diseases. Tobacco use, yes. Substance abuse again is a big issue in our country. Some influence maybe because of social media, though government is trying its hard to have a tobacco-free campuses, and some sort of TEFI guidelines are being implemented in medical colleges, in other colleges, in schools, everywhere. But this substance abuse is a big issue again. And if you look at the data of Global Youth Tobacco Survey 1 and 2, and so the trend in among youth is definitely increasing. So this is again a kind of area of concern for us to be taken care of, that this sort of behavior should be turned down. Obesity because of physical inactivity, definitely, and because of unhealthy food consumption, which leads to obesity, is another big risk factor, because all the diseases, non-communicable diseases, they start with the obesity first. Obesity is a kind of trigger factor, we would say, first alarm, which we can say about diabetes and hypertension. So these are some of the leading risk factors which are to hypertension in adolescents. Similar situation persists for diabetes also. So hypertension and diabetes, as we know, both are brother and sister, they go hand in hand. So situation is same. Risk factors are almost same for diabetes and hypertension. Though government is trying its hard, if we look at national NCD monitoring survey, which was done in 2016-17, so some targets were set by government of India at that time for NCD monitoring, which you called NCD monitoring framework, in which the targets were to reduce almost half to one third of premature mortality because of non-communicable diseases, raised blood pressure, harmful use of alcohol, physical inactivity, sodium intake, and tobacco use. Government is trying its hard, definitely, to reduce or to change that behavior, in which the targets have been already been set to reduce this. But so far, somewhere the implementation is an issue, or we can say there are some gaps in the policy, some bottlenecks in the care cascade, I would say. So as per my understanding, I have divided this care cascade bottlenecks into four parts. There are some gaps in awareness among youth awareness about limited knowledge of, because these are the diseases which has a very long asymptomatic phase. The symptoms develop very late in the life, or we can say after development of the complications, which leads to a difficult situation to handle. So this awareness gap is one of the important gap, or one of the important bottleneck in the care cascade. Second is detection gap. Though disease has a very long asymptomatic phase, but many of the youth, they remain undiagnosed because we are not detecting them. They are not going for screening. Government is not doing this screening for them, especially because that's not the age which has been decided with the policy and program. So that detection gap is a big gap. Third gap is because of linkages, because we are having difficulty in connecting youth who has been screened or who has been diagnosed. Suppose, for example, in NFHS5, there are few youth which has been diagnosed 4% prevalence, 4.5% prevalence, diabetes and hypertension. But what happened next? Are these youth being followed up properly by the health system? So that kind of linkage gap is there. And there are certain other gaps in the system which are leading to breakage in this care cascade, like gaps in policy formulation, gaps in programs, which we'll be discussing in subsequent slides. So some strategies which we can adopt to fulfill those gaps. For example, if we want to fulfill this awareness gap, so health promotion is one strategy. If you want to fill up the detection gaps, screening and surveillance, we can say is another strategy, especially screening. If you want to fill up the linkage gap, definitely affordable treatment and digitalization, because digital health mission these days is a big this thing which can be leveraged to fill up this linkage gap. And some other systems gaps we can fill up by youth specific policies, capacity building of our healthcare staff, and resource allocations. For example, I'll take one by one. For example, awareness gap. In awareness gap, definitely health promotion can be a best strategy. Now the question comes, where to implement this health promotion strategy? Uh, some pointers may be like we can implement this school-based health promotion programs, because that is the place where we can capture, or where we can target most of the youth in our country. It may be a systematic program, it may be a part of NPNCD program, or it can be a kind of opportunistic exercise which we are doing into bits and pieces in our country. For example, if we are celebrating today is a youth day. So like Dr. Kripal has taken an initiative to celebrate this youth day to generate awareness among people about this awareness among youth to about this non-communicable diseases. This kind of opportunistic exercises can be leveraged to promote health among youth population. So we have many health days in our country, a list of health days in our country, and each health day can be a kind of platform to generate awareness about non-communicable disease. So that's why I named it opportunistic exercise rather than regular activity till the government is not taking or not rolling out any systematic program. This is the one strategy which can work to promote health in our country for non-communicable diseases. In this line, AIIMS School of Public Health, AIIMS Jodhpur releases fact sheets. Like we released fact sheet about on Youth Day 2024, then we amended it on to Youth Day 2025. And we are planning to amend another fact sheet for Youth Day 2026, which will be released. So in which we are somehow denoting the prevalence, the risk factors, and some sort of awareness generation activities. This is one effort towards health promotion. So these are some of the, like we can say, opportunistic exercises. Second gap is detection gap. Definitely screening is the best tool to fill up this detection gap. The most important thing, again, I'm emphasizing it to reduce the cutoff for age, cutoff for screening of population in our country in NPNCD program. What should be the cutoff? That's a different question or different thing, but at least we should reduce to at least 20 years or 18 years of age. Second thing is opportunistic screening in pediatric OPD. That may be another area in which this youth population or adolescent population can be screened, because I could recall when this national program was started, it was started with opportunistic screening only. So looking at the resources, we have sufficient resources in pediatric OPDs. So at least that is the best place in which opportunistic screening can be started for this youth population. Third thing is, because we are already having CBAC checklist, we are already screening 30+ population in our country. We are already identifying, we are already taking family history for 30+ population in our country. So at least this high risk strategy can be adopted. Usually, as an epidemiologist, we talk about this population strategy and a high risk strategy. So suppose a family found with a positive family history of diabetes and hypertension, at least in that family, the youth or adolescent should be screened. So that kind of high risk screening can be incorporated till the government pulled up, or we can say pull sufficient resources for this program. And in line with that, screening protocols need to be updated in NPNCD program. I just took up the screening protocol. So I saw the frequency and age, for example, in hypertension and diabetes. The screening age is 30+ in the program, and it's once in a year. So the recommendation is, we can say we should look forward to reduce it to 18 years or below if possible. If you look at the screening program for diabetes, it is mostly for 30 plus age group. The same screening protocol can be used for adolescents, for youth population also, because the cutoffs won't vary. I had a discussion with endocrinologists, I had a discussion with medicine guys some 2 3 days back also, and they suggested the same cutoffs or same 140 milligram per deciliter can be a kind of screening cutoff for adolescents also, and can be definitely incorporated. So similarly for hypertension, if you look at the screening protocol for hypertension in NPNCD program, the age group is more than 18 years of age, which the cutoff is valid for this particular age group. But when it comes to screening, we are screening only 30 plus population. So we have protocol, we have science backed with us, we have evidences, sufficient evidences to incorporate into the program. Now it's only the implementation part, or we can say only the changes, the pooling of resources, mobilization of resources, which is required. So definitely there is a need to change those. Next strategy to fill up this detection gap is surveillance. Other than screening, surveillance is an important backbone to capture the data for these non-communicable diseases. Unfortunately, all of the surveys in our country, they majorly focuses on adults. They majorly focuses on 30 plus population. Few surveys like CNNS, as I told, and these days NFHS5 also, they have reduced the cutoff for age 15 plus population to screen for diabetes and hypertension. So India is moving towards to screen those adolescents and youth population, but somehow more focused is required. Because we do not have a nationally representative data on hypertension and diabetes or any other LCDs for youth population in our country. So though government is trying its best, as I told, there is a Vision 2035 in which public health surveillance in India has started school-based screening and surveillance. So hopefully these will be merged together, and in future we will be having a robust surveillance system for non-communicable diseases, and we'll be having a good data set for youth hypertension and diabetes in our country. Third gap is about the linkages. Linkages, I would suggest two strategies. One is affordable treatment and second is digitalization. Affordable treatment, though there are many studies on out-of-pocket expenditure in our country or a catastrophic expenditure in our country. But looking at the scenario, as those diseases are mostly concentrated in urban areas, and out-of-pocket expenditure studies also says that like in Indian system, most of the drugs of non-communicable disease, they are provided free of cost. So affordable treatment is not a big issue for a country. It can be definitely managed. But the second issue, which is related to data linkages, is a big issue. Somewhere we need to connect different ministries through digital platform. We can say like school health program in which we'll be doing screening, or we'll be doing some health promotional activities. Those will be linked with the data which is generated through health system or Ministry of Health, like data through PSCs, through CSCs, some sort of digital records like EHR and AIIMS and secondary and tertiary care hospitals. So that patchy data needs to be connected or linked together. Ayushman Bharat Digital Mission definitely can be very helpful in that. They can develop certain policies, and these are future directions in which the changes can definitely be made. The most important thing is, if a youth is diagnosed or screened positive with the diabetes or hypertension, that should not be out of the system, should be captured somewhere. There is a difference between referral and assured referral. We usually do referrals. Jao jaake dikha lena. But whether the person reached there or not, we should assure that. We should ensure the person has reached there, person has taken the medicines over there, and then some continuous follow-up, because that is the mainstay of treatment for any disease. And that should be there in non-communicable disease. The biggest issue is this loss to follow-up in non-communicable diseases. Other system gaps, definitely there are many gaps, but a few of them are, one is youth specific policies. If you look at the National Health Policy 2017, which is a recent one, there is a need to integrate youth non-communicable diseases into the policy. Maybe in the next policy it will be, but there may be some amendments into the program in which youth can be introduced, or youth, some specific guidelines can be issued for the youth. Second thing is workforce capacity. I could recall my MBBS days some 26, 27 years back. We used to have a very limited number of classes on diabetes and hypertension because those were not the priorities at that time. Most of the classes were on communicable diseases. Now the scenario has changed these days. So this workforce capacity, we need trained counselors, we need health workers, especially for youth care, because this is a different population. You need different type of counseling for this population. They are because different terms these days, Gen Zs and other, but the mindset is different. So you need different type of counseling skills. For that, definitely capacity building is required. And to change any system, definitely resources are required. You need resources. So some sort of priority, some sort of political commitment is required to mobilize the resources or to, we can say, leverage from different, we can say CSR fund or from different programs which are of less priority to this program to make this changes into the system. Finally, one or two slides about the prevention, because I come from a background which talks about prevention always. So we all know what are the preventive strategies: healthy diet, maintaining ideal weight, stress management, no substance abuse, physical activity regularly, and regular BP monitoring. These are some of the basic things which we all know. But when it comes to following those things, many of the adolescents, or we can say many of our own kids, they don't follow these things. So somewhere there's a need to change the behavior. And when we talk about prevention, we always go with the systematic approach of primordial, primary, secondary, and tertiary prevention. If you ask me about the primordial prevention, definitely healthy behavior should be promoted in schools and communities. That's a must. Health promotion should always be there. But again, as I told, there is a need to adopt a high risk approach into this particular program. So we can say high risk for youth screening, especially for those families which are positive, which has a positive family history for diabetes and hypertension. At least for that population, we can start screening. We can identify them. We can introduce some sort of lifestyle interventions in the early stage. So secondary and tertiary prevention, at least for this movement, at least for few years, for those families which have a positive family history, which are at high risk of developing non-communicable diseases. Though ideally it should be for everybody. Secondary prevention, early diagnosis and management should be for all adolescents and youth in our country. Tertiary prevention, definitely we will not talking about this particular movement because it's mostly for adults, because as I told, these youths, jitna bhi youth, young age, will be converted into adults in next 10 years, 15 years. So this adult, we need healthy adults also, because country will be young at that time also. We don't want complications or a lot of morbidities among adults because of early initiation of those diabetes and hypertension. So definitely tertiary prevention at this stage is a least priority, but primordial, primary and secondary prevention is definitely must. Now it's a collective responsibility. Some responsibility lies with the government, some responsibility lies with the health system, definitely. But at the same time, some responsibility lies with the youth also. Youth, you should know your numbers, get screened regularly. Though it's not in the program, but I would say, I would promote this, that youth should come forward. They should get screened regularly by their own through different facilities, so that those diabetes and hypertension can be detected early. They should follow healthy lifestyle. This is the most important thing, which is a most important behavior change, I would say, which is required from youth side. They should do regular exercise. They should follow balanced diet. They should manage stress. Unhealthy diet should be avoided specifically because, as I told, more than 50% of the risk factor is because of this unhealthy diet. And third thing is there is a need some advocacy. There should demand from youth side to incorporate youth policies or youth-centered policies into the NPNCD program. So these are some of the responsibilities from youth side. So in conclusion, I would say these hypertension and diabetes these days are no longer adult-only issue. They have definitely came into or trickled down into younger age group. It's a high time. Second is Youth Day is a call for action, screen early, act early, invest in youth health. That is very important because if we intervene today, India will be healthy in future. And detection, surveillance, and prevention. definitely they are mainstay of treatment so that we can shape India's health tomorrow. So this is all from my side. Thank you so much.
Thank you, sir. That was a very informative presentation. Our next speaker is Dr. Om Prakash Behra, sir. Sir is Regional Advisor Asia in Global Health Advocacy Incubator USA, who will speak on the topic Life Course Approach to Hypertension Prevention, Investing in Youth for Healthier and Productive India. Over to you, sir.
Thank you so much. And am I audible?
Yes, you're audible.
Okay, perfect. So I think this is a very timely webinar and occasion of National Youth Day, and also like as the present government has always focused on the importance of youth and on the principles of Swami Vivekananda ji. So I think this is a very apt like day for this topic and for the emerging challenges that our youths are facing. And I would like to thank Dr. C.B. Tripathi sir for for giving us the opening statement, as well as providing the principles of Swami Vivekananda ji, and also Dr. Manoj for setting the context of like how how the hypertension and diabetes in young India. Uh, I would I would have been glad if Dr. Pradeep would have joined, because that was a one step before my presentation, because it was on the addressing behavioral risk factors. But I think like I will touch on that, but I will first come on to the immediate section on life course approach to hypertension prevention and investing in youth for a healthier and productive India. So Dr. Manoj has set out a perfect stage for me to move forward, and on the National Youth Day overall, just a reminder that we do not only celebrate the energy of youth, but the main joy is holding the responsibility towards the future. So I would say as a mid-age public health personnel, so it is more important to be responsible and to guide our youngsters so that they can lead a very good future and a healthier future. As Swami Vivekananda ji always mentioned that strength is life and weakness is death. So in public health, overall now the funda has become that strength is in building hospitals. But to some extent, as a public health personnel, I do not agree to that. And in public health, strength is not in building the hospitals, but it is about early prevention, early action, and informed choices. And today, as my lecture is mainly towards the life course process, and which is again a development challenge for a disease like hypertension, in which I have worked since like last 4 years across systems, governance, and policy making. So it is a subject where in India we started advocating for decrease in the age of screening. So once during the school period, a the children are actually covered under the school health program. The National Program for Non-Communicable Diseases, they cover the screening population is from 30 year onwards. So what happens exactly between 18 to 30 years or 18 to 29 years is something which is worrisome. And as Dr. Manoj mentioned about like the early cases of cardiac failure, early cases of hypertension, that is something alarming. And that's why the entire focus of youth is very apt in today's India, where the entire population is a youth population. And as everybody understands that hypertension is a serial killer. But I would add, because our youths are affected, it is going to be a serious silent accumulator, and most of us are affected. And even before our first diagnosis, we do not know that we are affected, but we are affected. I would give you an example in which one of my friend, while flashing a new Apple Watch, so there is a feature of an ECG and he's only 28 years old. So he just like, he's an engineer and he's a biomedical engineer. So he said that like, this is an ECG, and he just like forwarded that ECG to me, mentioned ECG to me, and said that like, what are some of the findings? Means frankly, I was, because I'm like not a pure clinical guy. So I actually forwarded that ECG to one of my clinical friend, and he said that it's a early stage of a hypertension. So even if he didn't knew he's a fit, he's regular in gym, but he is having a hypertension, means he has developed already hypertension. And thanks to that Apple Watch that he was diagnosed, and right now he's under medication. So this is how the entire framing has become. It is not, hypertension is not only like a disease of old age or a middle age or a clinic-based problem, or it's a matter of medicine. The old framing is incomplete, and blood pressure does not rise suddenly at around 45 years of age or 50 years of age. Its trajectory is basically decided 2 decades earlier. That means during the youth, the dietary habits, inactivities, tobacco use, stress, sleep deprivation, etc., all accumulate silently. And by the time hypertension is diagnosed, organ damage has already begun. And that's why I always say it as a silent accumulator. Silent killer to baad mein hoga, but it accumulates all the negative things that our bodies have gone through, including like sleep deprivation and stress, which is for us at a young age, we feel that like it's common, but that's not common. That needs to be taken care. What is a life course approach? When in public health, in community medicine, we come across life course approach. We publish a lot of paper on life course approach. But what exactly it is, and what practical lines are what practical lines does this approach provide to our youngsters? So basically, if I simplify the entire like concept, a life course approach recognizes that health risks accumulate over time. That's why it's a accumulate. And early prevention has the highest impact. These are the two key aspects of a life course approach. In a different, if we want to simplify it theoretically and diagrammatically, it is superb. But the two high-level things that I would like to provide to all the listeners is health risks accumulate. So develop very good healthy habits, and early prevention. Annual monitoring of health is important, and that should start early. In hypertension, the risks begin early. The progression is gradual, but the prevention should be continuous, and as early as, like, I would say 20 years of age. We have seen like in most of the news channels, badminton player, like a healthy fit badminton player, like collapsing. Might be that is n number of causes, but if that would have been like a early screenings, then might be that case would have been prevented. We have seen like very young guys like moving across road and like suddenly falling down, and later we understand that like they were like having chronic hypertension, and that's why intervention can only come if the prevention part is taken care and the prevention part is done earlier. The most effective prevention happen even before the first high reading and not after the first prescription. So whenever, like, even if an Apple Watch is able to like screen us, then I would say that like that's the best health intervention for if somebody can afford it. And why youths are the strategic entry point? Youths overall are the most powerful leverage point for prevention. In public health, if a certain means one line recommendation I could provide to NMC is why not start a subject which actually focuses on taking care of the health of our youths. And this is the stage, because this is the stage where the habits are forming. The behavior change is feasible because they are like very young. The risks are reversible. And this is also the age where early onset of diseases start. At the same time, the risks, the multiple risks of be it NCDs, mainly NCDs, that can actually, we can prevent. And it overall reduces the health financing term of like reducing the catastrophic health expenditure, and it can protect families. So overall early prevention is like not medicalization, but it's basically an empowerment. And when we say like hypertension overall, so in prior to like me working in non-communicable disease like arena, so when I saw hypertension, it was a different way of thinking in 2020 versus in 2025 when I'm seeing the non-communicable diseases, and specifically as my topic is hypertension. Hypertension is not an individual failure. It's a systemic failure, I would say. And we often blame like individuals for hypertension. But we have been taught that public health teaches us that choices are shaped by systems. Then it is not an individual thing, it's a system-based failure. And why even it is happening? Youth today are exposed to unhealthy food environments, sedentary education systems, high psychological stress, and therefore hypertension prevention requires a consolidated effort or a comprehensive efforts of policy coherence, a intersectoral action, as well as an accountability beyond health departments. Health departments come very late in the picture. Our food environments are shaped up since like our childhood. So who is to blame? Or whether there should be effective guidelines, or whether it's a problem of implementation. As Dr. Manoj mentioned, that implementation is the key. If we want to reduce the overall burden, implementation is the key. Even if there are certain guidelines, we even do not know about it. Like way back in 2022, when the trans fatty acids like was banned, I didn't ever heard about it. Even like before I entering the program, I've never heard about like what is a trans fat. I read it in my biochemistry books, but I never knew about like till I implemented that program. So that's how policies are there. We do not know how it's get implemented. In fact, like many of the food safety officers didn't know about that. So when like taking forward the point Dr. Manoj made, that how do we integrate the youth into health systems and the national program? I would say overall hypertension or diabetes or any like early or any NCDs cannot remain clinic centric. It needs to be integrated in schools and universities. It needs to be integrated into NSS, NCC, as well as youth platforms, and overall the community and the digital spaces. In fact, like I have seen my juniors, I have seen like my seniors, reels are the new fad. And I would say that like in every household, it's very common. So why not also bring out some creative digital like interventions, where if you are watching a reel, then suddenly the ad or suddenly a reel on healthy lifestyle comes in. So this is something which is needed right now, and also strongly advocate for like a university health program. I always have been like highly vocal about the need of a university health program in India. And recently in Karnataka, when I was like giving the speech, the health minister of Karnataka, Mr. Dinesh, he mentioned that like they would be taking up some steps, and immediately Rajiv Gandhi Health University came into action, and they are developing some sort of guidelines for taking care. I would think that this kind of guidelines should not be limited to a state or 2 or 10 states, but it should be a national guideline. And whatever the advocacy is needed, we need to do that kind of advocacy to bring it to the national level. Overall, if we see when like hypertension as a life course approach, it is not limited to only health. It is also having an economic and the development lens. And that's why I always say that like the health financing perspective. And it's not a health issue, it's also an economic issue. if a young guy is diagnosed with like cardiovascular diseases, it overall leads to the total number of productive years. If in a setting like India or like our neighboring countries where there are mostly one earning member, one or two earning member, then overall the house the house suffers. And overall, there is an increased public expenditure also from the government side. So each rupee invested in early prevention can actually yield highly. So I do not know the exact in WHO best bias for NCD. There is actually a calculation. Well, each dollar spent on prevention can save you around $8 to $9 on treatment. So youth-based prevention for me is one of the highest return public investments ever. The third important part is the vision, the national vision. Our honorable Prime Minister having like he's I would say the biggest champion of youth health, and from Fit India to Eat Right movements and multiple movements, our Prime Minister has advocated for the best of it. And it's actually in line with Swami Vivekananda ji, and who saw youths as the builders of a strong nation. A strong nation a nation cannot be strong if the youths are burdened with preventable chronic diseases. And that's why health youths are the foundation of economic resilience, social stability, as well as sustainable development. So combining the entire health part, education part, economics part, and the national vision, overall for me, always the national call to action is the biggest. The national duty is the biggest among everything. So a final call to action from my side would be not only hypertension, all kinds of non-communicable disease must begin long before diagnosis. And that's where the annual health screening comes to place. And overall, youths are the solution. And if our country wants to realize its demographic dividend, we need to invest early, act systematically, and empower our youth. And that's where the university health program needs to come into existence. And overall, let us move from like treating diseases as doctors. We need to move away. We need to move away from like building. We need to like move out from treating diseases to building lifelong health. And why? Because healthy youth today means a stronger India tomorrow. With this concluding sentence, I would like to close my session. And overall, thanks. And over to you, Dr. Krupal. Thank you so much.
Thank you so much, sir, for your insightful words. Our next presentation is from Dr. Venkatesh Karthikeyan, who is NCD Chair, World Medical Association (JDN), who will speak on from policy to practice role of youth engagement in strengthening national NCD programs. Over to you, sir.
Sure, thank you. Is my screen visible and am I audible?
Yes, it is visible and audible.
Okay, thank you so much. Good afternoon, everyone. First of all, I'd like to thank Gujarat NCD Control Initiative for organizing this important program, aligning with the recent United Nations high-level meetings on NCDs. And it is a pleasure listening to great speakers like Tripathi sir and Dr. Manoj sir. And I would like to thank Dr. Kripal sir and Dr. Om Prakash sir for inviting me to be a part of this event as well. Our previous speakers beautifully highlighted how serious is this problem of NCDs, especially amongst the youth, and how to address this NCD risk factors and how this nation building exercise can help in bringing up a better nation when we are involving the youth. So for the next couple of minutes, we shall discuss about what is the role of youth engagement in strengthening the NCD programs. I'm Dr. Venkatesh Karthikeyan from AIIMS Patna, and I'm the NCD chair for the Junior Doctors Network of the World Medical Association. Just a short few lines about World Medical Association. WMA is an international organization representing 1 crore physicians. It is started in 1947 and currently we have a membership of more than 115 national medical associations. The purpose of the WMA is to serve the humanity by endeavoring to achieve the highest international standards in medical education, medical science, medical art and medical ethics, and healthcare for all people in the world. Amongst the different areas of interest, one core area of interest of World Medical Association is the non-communicable diseases. As we know, non-communicable diseases are also known as chronic diseases and are a result of multiple factors like genetic factors, physiological factors, environmental factors, and behavioral factors. And NCDs are killing at least 43 million people per year, which is equivalent to 75% of non-pandemic related deaths. Discussing about the burden, premature mortality, 18 million people die before the age of 70. That is due to NCDs. Of this, 82% of these premature deaths occur in low middle income countries like India, and out of all the NCD deaths, 73% are in LMICs. Here we could see earlier in 1990s, high-income countries like Switzerland, Germany, and Singapore were suffering the most from non-communicable diseases. But over the past 3 decades, the trend has tremendously changed, and Southeast Asian countries are in the top of this board, and leading to a lot of NCD-related mortality. The amount figure shows that about 55 percentage of total deaths in India are from non-communicable diseases. Though this may seem as a relatively smaller number when compared to other countries, like the global percentage of NCD related death is 65 percentage, whereas for India it is 55 percentage. Though it may look comparatively low, what is more alarming is that in global level, the annual percentage increase of NCD related death is 0.34 percentage, whereas the annual percentage change of increase in NCD mortality is 1.3 percentage in India, which is alarming and showing that how rapidly this burden of NCDs is evolving. Not only about the mortality, NCDs are also costing a lot of DALYs, which is disability adjusted life years, which is nothing but a sum of years lived with disability and years of life lost. Again, we could see around 55 percentage of DALYs in India are due to non-communicable diseases. Apart from DALYs and mortality, NCDs have a great socio-economic impact, and poverty is closely linked with non-communicable diseases. Vulnerable and socially disadvantaged people get sicker and they die sooner than people of higher socio-economic positions, especially because they have limited access to health services. And this is also increasing the household cost or the out-of-pocket expenditure, as highlighted by the previous speaker. In one of my recent studies at Madras Medical College, among the diabetic foot ulcer patients, we noted that the mean cost for diabetic foot care is around 30,000 rupees, Indian rupees, which is very high for a country like India. So this NCDs is often leading to high out-of-pocket expenditure and catastrophic health expenditure, which is closely linked with poverty. There are a lot of national programs related to NCDs, starting from NPNCD to Ayushman Bharat and different health programs related to NCDs. But however, the involvement of youth, the engagement of youth in these programs is limited. It is very essential to engage youth in these health programs because youth and the adolescence is the inflection point where lifestyle patterns like dietary choices, exercise routine, and substance use are formed. So engaging youth ensures healthy habits are formed, as mentioned by Dr. Bera sir earlier. It is the right time to catch them, and this will give us triple dividend benefit. That is, it is going to give us healthy adolescents and healthy youths today. It is going to give rise to healthy adults tomorrow, and eventually the upcoming generations also tend to be healthier when we are going to invest on youth engagement. Also, talking about demographic dividend, as India is a country of youth, protecting the youth from the early onset of NCDs prevents the demographic dividend from becoming a demographic burden, which is due to premature mortality and years of life lost due to non-communicable diseases. Engaging youth is also essential because youth can influence the behavior of peers. Peer education is a powerful tool and it is used only in few national programs. And in this era of social media and digital influence, as rightly pointed out by the previous speaker, it becomes mandatory to involve youth and involve the social media and digital influences to bend this curve of non-communicable diseases. Youth participation in policy-making forums empowers the next generation to hold the governments accountable for NCD prevention commitments and drive structural and environmental changes both at the community level as well as at the national level. And of course, the young people have the right to negotiate the future of health of the communities in which they are going to live. And these youth have a different perspective, they see things with a different lens, and this uniqueness, this fresh perspectives can be leveraged to strengthen the national NCD programs. Also, this is sharing one of my recent works where we tried to find out whether a Bluetooth enabled sphygmomanometer and a Bluetooth enabled glucometer can be used in traditional in community settings for NCD screening. This, of course, is a example for innovation and research, and involving youth is very much essential to facilitate coming up of many such innovations, and to have more research outputs related to non-communicable diseases. So there are different stakeholders like the schools and college students, youth leaders, as previous speaker said, NCC, NSS, youths from civil society organizations, youth from NGOs, sports players, cricketers, youth with lived experiences, very important but often neglected, medical students, and young doctors. And this World Medical Association Junior Doctors Network is an international platform trying to represent the young doctors, especially in the policy making tables. So, the past couple of years, the World Medical Association Junior Doctors Network is also part of the World Health Assembly, which is held at World Health Organization headquarters, Geneva, every year. Last year, I contributed to the drafting of this statement from the World Medical Association, which again highlights that there is a need to increase the investment in health workforce, young health workforce, for tackling the non-communicable diseases. We are also trying to engage continuously with the World Health Organization through different platforms, like the recent WHO Global Coordination Mechanisms on Non-Communicable Diseases General Meeting. And fortunately, in the last month, WHO has come up with a declaration on NCDs, which very critically highlights the importance of youth engagement for addressing this problem of non-communicable diseases. Also, last year, the fourth Global NCD Alliance Forum was held at Rwanda, where we advocated for civil society led advocacy for prioritizing the domestic resource mobilization for non communicable diseases. Again, thanks to Global Health Advocacy Incubator and Dr. Om Prakash Berasar for the leadership and facilitating this initiative. And as a continuation of the conference, we had a youth workshop where we came up with this Kigali Youth Declaration. If you could Google it up, you will get the full declaration. But just few important points to highlight from from that declaration is that the declaration advocates for equipping the young people with skills and quality health information to tackle the non-communicable diseases. Also, it advocates establish effective communication channels between the young people and the key stakeholders to support evidence-based decision making. So there should always be a channel which should be open between the youth and the policymakers, so that the voices of youth are heard before any major policy change. And not only in the designing of policy, youth must also be involved in monitoring the progress, how well things are getting implemented on ground. Also, funding related to NCDs should be aligned so that youth-centered care models are given a scope. And this is a picture from Bangkok, where I was representing the World Medical Association at the World Federation for Medical Education. So this picture is a beautiful picture because mainly because you could see there is a representative from IFMSA, which is an International Federation for Medical Students Association, and a representative myself from the World Medical Association Junior Doctors Network. So it is not a one-time event where young people are representing in such high-level forums. The structure of World Federation of Medical Education is such, there is the executive body of WFME has one spot for IFMSA and one spot for WMH ADN, who are members who has voting rights. So this makes sure that the engagement of youth is institutionalized within the formal policy processes. So any decision of World Federation for Medical Education needs to be kind of co-approved by both the young doctors as well as medical students representative, which I find is very interesting because it kind of formalizes the way youth are engaged within policy making. Again, within our Indian context, for non-communicable disease-related advocacy, Dr. Om Prakash sir and GHAI has conceptualized this concept of Young Doctors Health Parliament. In a recent meeting, we brought together high-level stakeholders, including the NCD head of the Indian Council of Medical Research, Dr. Kripal sir was there, and leaders of the Indian Medical Association were there, and we were advocating for the engagement of youth in non-communicable diseases. Again, we have published this in detail, which can be referred to if required. So to conclude, non-communicable diseases are detrimental, and it's high time that we recognize the need to have a whole of government and a whole of society approach. And it is again a high time to include youth, and inclusion is not only limited to just having them on paper, but to create a safe environment for meaningful engagement. Also, it is essential to establish a communication channel between the youth and policymakers, and keep this communication channel open so that youth's voice are heard before making these changes. And of course, youth should always be given an opportunity to be a part of policy making. I would like to conclude by quoting this from Swami Vivekananda ji, that my faith is in the younger generation, the modern generation. They will work out the whole problem like lions. So let us empower these lions. Let us utilize these lions and bend down the NCD curve so that we all can march towards a Vikshit Bharat. Thank you so much for this opportunity.
Thank you, Dr. Venkatesh. Thank you to all our speakers for their valuable contributions in this webinar. To formally conclude the webinar, I would like to invite Dr. Krupal Joshi, Principal Investigator of Hypertension Support in Gujarat Project from AIIMS Rajkot, to deliver the vote of thanks.
Thank you, Dr. Stuti. As a host of the webinar and PI of this project, I extend my most humble and sincere gratitude to all who grace our Youth Against NCD program on this auspicious day of the National Youth Day. I convey my deepest gratitude to respected our Dr. C.B. Tripathi sir, who is National President of NMO, for sharing the profound life lesson inspired by the philosophy of Swami Vivekananda, which serves as a powerful source of the inspiration for our youth. I sincerely thank Dr. Manoj sir for kindly accepting our invitation on short notice and for making time to join the webinar despite of his busy schedule. I know sir is very busy, but once I ring up sir, tell, okay, I am available, and you just make my time schedule this, and I'll be there. So thank you, sir. And his willingness to support us and share his valuable thoughts greatly enriched the session. We truly appreciate his time, effort, and commitment to guiding and motivating the participants. My heartfelt appreciation is extended to Dr. Om Prakash, who is Regional Advisor for the Asia from Global Health Advocacy Incubator, USA, for his constant encouragement and unwavering support across all the NCD related initiative for our states. And he's always ready. He's always available. Okay, you want to do something on NCD? Okay, I am here to help you. Yes, and he also guides us. I'm also truly grateful to Dr. Venkatesh, my dear friend, Dr. Venkatesh, who is the NCD chair, World Medical Association, and for the network of the JDN, who is from AIIMS Patna, a dynamic youth leader in the medical fraternity, very influencer, whose influential global work in the NCD prevention and control continues to inspire the medical youth internationally. And today, more than 200 participants joined the program. Now, my message to the participation, we kindly request everyone to complete the post-test. It is mandatory to receive the certificate. And my heartfelt appreciation goes to my cherished AIIMS Rajkot colleagues for their tireless support, and every participant whose gracious presence and thoughtful engagement have made this grateful truly memorable. With deepest respect and warmest regards, thank you all. Jai Hind.
Thank you. Thank you, Dr. Krupal.